Today, we are going to speak about movement disorders in emergencies. Myself, Dr. Prashant from Bangalore, India, who is going to cover up this vast topic down here. So, what are we going to talk in this session? I'm going to talk about what are movement disorders emergencies, approach and management of some of classical movement disorder emergencies, and what to remember at the end of the day. So, what is a movement disorders emergencies? Movement disorders emergency is a rapidly evolving disorder which develops within hours to days, in which a failure to diagnose and treat may lead to significant morbidity and mortality. So something, if you don't diagnose it and which is rapidly evolving, will end up with a disastrous situation, is considered as a movement disorder emergencies. So what are the different types of movement disorders emergencies? As we approach to any of the movement disorders, that based upon the type of primary movement what we see, the underlying etiology may vary, but it can be classified as hypokinetic emergencies and hyperkinetic emergencies. Hypokinetic emergencies include acute Parkinsonism, drug-induced movement disorders emergencies, neuroleptic malignant syndrome, Parkinsonism hyperpyrexia syndrome, serotonin syndrome, complications of Parkinson disease, lethal catatonia, to give few examples. Then, in hyperkinetic emergencies, we have Dystonic Storm, Chorea Ballisim, Chorea Storm, Chorea Paralytica, myoclonus, acute dystonic reactions, tics, delirium tremens, etc. So we are going to talk each one of them to cover up some of them in a brief, some of them in slightly more detailed perspective to look into it. So let's talk about emergencies in Parkinson disease. The common emergencies in Parkinson disease includes related to falls and falls related complications, motor fluctuations causing issues, that is severe dyskinesis on-off period, and development of acute psychosis either due to the disease process or due to the drug-induced psychosis. This is completely covered in a different topic in relation to Parkinson disease. I'm not going to talk about these 3 points down here. Going forward, this is a middle-aged lady who presented with sudden onset of slowness, which was noticed over a day, where she has been become significantly slow, not able to perform her day-to-day activities without any other issue, no other history of fever, trauma, or any medications was there. When she came to us, when we examined, she was having significant slowness, rigidity, considered to have an acute onset Parkinsonian features. Imaging done showed an acute infarct, which can be seen in her centrum semioval and corona radiata region, along with the basal ganglionic region. So what are we talking about here? Is acute Parkinsonism. Acute Parkinsonism can occur in various situations and circumstances, which usually develops over hours to days. It can be drug-induced due to neuroleptics, antiemetics, anticonvulsants, cytotoxic agents, or antidepressants, or it could be related to intoxication such as carbon monoxide intoxication, methanol intoxication, OP poisoning, MPTPs, manganese, cyanide, and disulfiram. Acute Parkinsonism can also be seen in structural disorders such as SDH, hydrocephalus, or secondarily following to infections or metabolic disorders, which are the commonest probably what we see, such as pontine or extrapontine merinolysis, diabetic uremia, hepatic encephalopathy, and in some circumstances it can be genetic causes such as rapid onset dystonia, Parkinsonism, or acute decompensation in Wilson disease. There are other causes of acute Parkinsonism, which includes autoimmune disorders, which has to be, or vasculitic phenomena, which we should remember for any patient who has to come in. It's very important to recognize acute Parkinsonian emergencies as most of them tend to have treatable causes, early diagnosis, and early treatment make significant difference for the overall outcome of these patients. Going forward, Mr. X, an 81-year-old known case of schizoaffective disorder, was admitted in a hospital due to worsening. He received loxapine for his psychotic symptoms and methotrexate for sleep disturbances. Within 3 days after admission, the methotrexate therapy was stopped because of somnolence, and loxapine dose increased to 65 mg per day at bedtime. 12 hours after this change, the patient had diaphoresis, tremulousness, urinary incontinence, and some cognitive impairment. His temperature was elevated, and although normotensive, he had tachycardia and exhibited Parkinsonian features, including tremor, rigidity, and unsteady gait. His lab investigations revealed mild leukocytosis along with minimal elevation in the liver enzymes. His CPK was significantly elevated and with a normal CK-MB fraction and cardiac troponin levels. His other lab results, including electrolyte levels, were within normal range. So what are we seeing? Here is a person with a behavioral disorder admitted for an acute emergency or worsening, treated, and during this treatment, some medications are given and then withdrawn. And during this phase, he has been developing a dramatic change of symptoms with autonomic dysfunctions, Parkinsonian features, and this is what we call it as Neuroleptic Malignant Syndrome or NMS. So what is Neuroleptic Malignant Syndrome? It's a clinical syndrome comprised of fever, rigidity, mental status change, autonomic dysfunction, and other movement disorders. It was initially described as a triad of rigidity, dysautonomia, and mental status alteration, and usually associated with neuroleptic drugs. The incidence is around 0.02% of patients receiving neuroleptic agents, and commonest risk factors includes neuroleptic drug initiation, dose change, male gender, younger age, SSRI lithium combinations, high temperatures, dehydration, exhaustion, and previous NMS episodes. The classical features include the prodromal signs of most common is the muscle rigidity and altered mental status. That's a triad among the triad which has been described, along with other features such as obtundation, catatonia, tachycardia, tachypnea, labial blood pressure, dysarthria, dysphagia, diaphoresis, sialorrhea, incontinence, myoclonus, low-grade fever, and elevated serum CPK levels. As the symptoms progress, you start to have various clinical signs and symptoms, which include hyperthermia, muscle rigidity, tremors, autonomic instability, along with lab features showing elevated muscle enzymes, myoglobinuria, leukocytosis, metabolic acidosis, and elevated serum catecholamines. Make sure that other systemic causes or toxic causes of hyperthermia are always ruled out when you're working up. The key diagnostic features for a person with NMS is exposure to dopamine antagonist or dopamine agonist withdrawal, hyperthermia, muscle rigidity, mental status alteration, CPK elevation, elevated sympathetic nervous system lability, hypermetabolism, negative workup for infections and metabolic or toxic causes. So these are the key diagnostic symptoms what we look in a patient with suspected NMS clinical features. Most of the patients develop NMS after exposure to neuroleptics within 24 hours in about 16% of the patients, and about 66% develop within a week, and about more than 95% of the people would have developed within 30 days of the exposure. The commonest question when we get is, or when you get a doubt of suspected NMS is, what are the other possibilities? Other possibilities which can mimic is neuroleptic malignant syndrome is serotonergic syndromes and malignant hyperthermia. This nice difference table, which has been published in 2015 article, gives a classical factors, triggering factors, onset, positive agents, associated clinical features, and treatment differences between neuroleptic malignant syndrome, serotonergic syndrome, and malignant hyperthermia. Just to remember is, for neuroleptic malignant syndrome, the causative agent is usually classically the newer antipsychotics or antiemetics, levodopa withdrawal, whereas for serotonergic syndrome is SSRIs, SNRIs, tricyclic antidepressants, MAOB inhibitors, L-tryptophan, amphetamines, and cocaine. Whereas for malignant hyperthermia is usually volatile anesthetics and succinylcholine. Most of the symptoms remains almost similar, but the severity can vary across, and based upon the underlying etiology, pharmacological treatment do vary to certain extent, what we should remember. Recognition of underlying cause helps you to differentiate these three critical important movement disorders emergencies. How to manage a person with suspected neuroleptic malignant syndrome? It based upon at what stage you are seeing the patient. In stage 1, primarily people will be having a slowness or a Parkinsonian features in the form of rigidity and tremors. In this case, just reduction or switching back to antipsychotics will help you out, or in some patients, anticholinergic agents could suffice. As symptoms starts progressing further, people go into stage 2 or catatonic phase where rigidity, mutism, stupor can be noticed. Here, it becomes important to discontinue, reduce, or switch antipsychotics has to be done, and benzodiazepines, preferably lorazepam, can be given round the clock. If the patient passes on to the next phase, which is stage 3 called as early NMS, along with the earlier features, patients start developing tachycardia, higher body temperature, hyperthermic features starts developing. It's very important to discontinue antipsychotics, closely monitor, and continue with benzodiazepines. Subsequently, when patient develop moderate features of NMS, they develop severe catatonia and have higher tachycardia and higher blood temperature, higher body temperatures, requires aggressive treatment, including good fluid management, cooling measures, and considering, in addition to benzodiazepines, will be bromocriptine or amantadine, or in certain cases, to consider electroconvulsive therapies can be considered. Then, in patients who have severe NMS with hyperthermia, fluid management is critical along with cooling measures. Dantrolene sodium can be considered usually given in a dosage of around 1 to 2.5 milligram per kg IV every 6th hourly for 48 hours. Usually not easily accessible in most of the centers and cities. That's the limitation what you need to understand. Or then we can have bromocriptine, amantadine, and consider ECTs. This shows the variability of approach to management of NMS based upon at what stage of the symptoms you have seen and how to manage NMS. Most of the patients with NMS recover within a week, and most of them, almost 63% of them, recover within a month. 30% of risk of recurrence has noticed with repeat exposure to neuroleptics, and mortality risk is around 20 to 30%. Now going to a next similar example where Mrs. S, known case of Parkinson disease, was admitted for deep brain stimulation, underwent bilateral ST and DBS with overnight withdrawal of dopaminergic agents. Surgery was uneventful. However, in immediate post-operative period, she was started to notice blood pressure fluctuations, profuse sweating, worsening of tremors, restless, and agitated behavior. Investigations revealed leukocytosis with rising CPK and increased CPK levels above 50,000 over 3 days associated with high temperatures. If you look into this case history looks similar to our neuroleptic malignant syndrome, except the only thing is there has been no exposure to neuroleptics, but there has been withdrawal of dopamine agents, especially levodopa, over 12 hours or 24 hours for the surgical limitations what we had. So even though it is similar, we call this set of patients as Parkinsonism hyperpyrexia syndrome, where this disorder is similar to NMS, triggered by sudden withdrawal of levodopa, amantadine, among other dopaminergic agents, and is reported under variety of names such as NMS or NMS-like levodopa withdrawal hyperthermia, or Parkinsonism hyperpyrexia syndrome, lethal hyperthermia, dopaminergic malignant syndrome, acute dopamine depletion syndrome, and clinical features remain almost identical to neuroleptic malignant syndrome. Treatment is early recognition and rapid reintroduction of levodopa along with other care similar to the NMS what we discussed previously. Next, movement disorders emergencies would be serotonergic syndrome. Serotonergic syndrome, as we discussed in the previous section, it occurs due to combination of two or more agents which enhance serotonergic activity. It's mostly abrupt in onset and relating to agitation, mental status changes, myoclonus, ataxia, postural instability, hyperreflexia, rigidity, and dysautonomia. Commonly implicated agents are SSRIs, SNRIs, tricyclic antidepressants, MAO inhibitors, amphetamines, cocaine, and tryptophan. Treatment is first is withdrawal of the offending agents, utilization of 5-HT receptor blockages such as cyproheptadine, methylsergide, and considering benzodiazepines and supportive treatment similar to the line of neuroleptic malignant syndromes. Mortality rate in serotonergic syndrome varies between 2 to 12%. Now, going forward to the next movement disorders emergency, that is dystonic storm. Dystonic storm is a malignant hyperkinetic movement disorder emergency in which rapid deterioration of dystonia requires emergency intervention. So why this happens? Many times dystonic storms happens due to increased pallidal output, leading to increased dystonic activity, leading to increased spinal mediated tone, then fever, rigidity, increased CPK and leukocytosis. Or it can also happen in some of the metabolic changes such as decoupling in Wilson disease, biotin thiamine responsive basal ganglionic distress, where there is increased serotonin release. This chemical changes triggers the brainstem mediated triggering factors leading to occurrence of the end results. Or in certain set of patients, it can be related to sudden withdrawal of intrathecal baclofen withdrawal or autoimmune disorders or toxic causes which takes away the suppression leading to increased spinal mediated activities leading to occurrence of a sudden dystonic crisis. Or due to peripheral muscle disease such as malignant hyperthermia which can present like this, or due to dopaminergic blockade which happens due to hypothalamic storm leading to occurrence of dystonic storm. So there are different reasons. The end result is increase in spinal mediated tone, fever, rigidity, increase in the muscle enzymes and leukocytosis leading to occurrence of dystonic storm. So dystonic storm has two components what we should remember. One is severe generalized dystonia, then systemic symptoms. That includes fever, tachycardia, tachypnea, hypertension, sweating, and autonomic instability. This can be accompanied by other movement disorders such as chorea, Ballisim, myoclonus, and along with the lab features of leukocytosis, elevated muscle enzymes, high CRP, myoglobinemia, or myoglobinuria. Other associated features could be, or commonly noticed is among this dystonic storm is commonly noticed in pediatric groups. Known patient means patients who already have a pre-existing dystonia rarely presents as a de novo. Most of the patients, or 1/3 of the patients, are unprovoked. Triggering factors includes infections, medication changes, or surgical procedures, and it's commonly seen in disorders associated with Wilson disease, cerebral palsy, DYT1, PANC, rapid onset dystonia, Parkinsonism, osmotic demyelination syndromes, mitochondrial encephalopathy, biotin thiamine responsive basal ganglionic disease. So when you have this suspicion and the pattern what it happens, you know what has to be considered. Dystonic storm has to be differentiated or can be confused with other storms such as choric storms, oculogaric. These are the different types of storms which are nicely been described by Termasab in 2017 about different types of differential diagnosis of dystonic storms, which please you can go through the article to understand this differential diagnosis of dystonic storm. So what is the course? Whenever there is a trigger, there is a prodrome phase where the patient's dystonia starts worsening. The best is to pick up here and treat it. If you miss the dystonic storm prodrome phase, there is a sudden dip leading to a dystonic storm and then which progresses over a week, and before that recovery starts happening. Based upon the underlying cause and treatment, recovery can span over 4 to 6 weeks, where leading to complete recovery or a partial recovery, then subsequent later down the time, a relapse can still happen. So when you suspect a dystonic storm, how it has to be managed? There are two important components when you see a dystonic storm. That is the first 24 hours and the subsequent week or the weeks, how you manage it. Critical is when you suspect a dystonic storm, admit to ICU, work up for infections. If any infectious reason is there, make sure treated with appropriate antibiotics. If no infectious reason is there, look whether the symptoms were precipitated by some pharmacological means, by withdrawal of a pharmacological agent. If yes, restore it. If no, then look for what was the underlying cause. Was it a known primary dystonic disorder such as DYT1 or primary dystonias? Yes, which has presented with, then consider surgical interventions such as DBS ITB. If not, consider for dystonic storm protocol. So what is a dystonic storm protocol? It contains of supportive care, which includes hydration, antipyretics, antibiotics, cooling blankets, analgesics, monitor for CPK along with that, and temporary measures with short-acting anesthetic agents such as midazolam, propofol, pancuronium can be considered to reduce the muscle rigidity which is going on in the bed, or to give a sufficient muscle relaxation. Dystonia specific is a classical Marsden cocktail, which is a combination of tetrabenzene, dopamine receptor blockade agonist, and an anticholinergics. Or you can consider independently other medications such as benzodiazepines, baclofen, anticonvulsants, bromocriptine, dantrolene, acetazolamide, and lithium. Various medications have been tried because dystonic storms are not so easy to manage with different dosages, and to see how it works out. If medications are not giving a satisfactory improvement, surgical therapies or intrathecal baclofen are considered as a choice of treatment for patients with dystonic storm. Please do remember that there's a mortality around 10% and efficacy of medical management is also around 10%. So what is this we are seeing here? This is a middle-aged lady or a lady who presented with sudden onset flinging movements of her right upper limb and right lower limb, for which she was not able to do any task. So what she was having is, what you can see, this is the imaging findings along with, if you leave out the incidental finding, what was noticed. What she was having is Chorea Ballisim or a classical hemichorea hemiballism syndrome. It occurs due to ischemic excitotoxicity of GABAergic neurons, leading to hyperdensity. What we see in the T1 or in the CT scans is due to the protein hydration inside the cytoplasm swollen gametocytes, and commonest cause is hyperglycemia, what we see, followed by vascular lesions. Treatment is identification of underlying etiology, and in this case, management of blood sugar levels and treatment. Most of the treatment has a favorable outcome, but do take some weeks' time to get some sensible clinical improvement. Next is people presenting with sudden onset acute tremors. The causes of occurrence of acute onset tremors are wide and variety, which includes and needs to be assessed based upon the underlying cause. And these include drugs, infections, autoimmune disorders, vascular causes, metabolic, functional disorders, and structural causes. Recognizing these and treating them specifically will help to give a satisfactory result. Now, what are we seeing there? This is an historical video of patients who were aggressive, running around, staying in a mentally care center, have standing in a stable phases for hours and hours without moving a bit. What we are seeing now is called as lethal catatonia. Lethal catatonia is extreme motor excitement followed by stuporous exhaustion, coma, cardiovascular collapse and death if not managed properly. It's also known as Bell's mania, acute delirious mania, delirious actum, psychotic exhaustion syndrome, Sheets cyanotic syndrome, etc. Please do remember that it's not that all patients have a mortality, but significant number of patients, if not treated, lead to that. Hence, the term malignant catatonia was coined. It has been this mortality has significantly reduced after introduction of proper therapy for the patients with malignant catatonia. The symptoms are similar to many of these what we discussed during this time about all these emergencies, which includes hyperthermia, catatonic excitement or stupor, other catatonic features such as mutism, negativism, cataplexy, posturing, echolalia, echopraxia, staring, along with Parkinsonian features, altered consciousness, and autonomic dysfunction. Lab findings do show muscle enzyme elevation, leukocytosis, low serum iron, and decreased perfusion, frontal perfusion on SPECT. The classical excited presentation includes extreme hyperactivity and progression of hyperthermia prior to onset of stupor, and stuporous phase presentation includes primarily stuporous, more commonly in the newer therapy era. So this is what we need to remember at excited presentation and the stuporous presentation for a person who is presenting with suspected malignant catatonia. Can occur due to various causes in addition to pre-existing psychiatric disorders such as schizophrenia, mood disorders, or periodic catatonia. It can be seen in cerebrovascular, CVA events, or structural disorders such as periventricular diffuse penieloma, glioma of the third ventricle, angioma of the midbrain, or drugs and toxic status such as postoperative state, barbiturate withdrawal, clonazepam withdrawal, tetraethyl lead poisoning, toxic epidermal necrolysis are some of the examples to talk about along with infections and metabolic causes. So the causes of catatonia are wide and varied, need to be systematically approached, including for all treatable causes, and need to be addressed the underlying cause. So primary care still remains the supportive care of underlying, such as with adequate hydration, antipyretics, antibiotics, cooling blankets, analgesia, and treatment of infections or metabolic corrections where and when required, along with discontinuation, reduction, or switching the antibiotics where appropriate. Benzodiazepines will work efficiently when started earlier. However, later ECTs or ECT should be initiated early, bilateral twice daily and every other day for 5 to 15 cycles. If all these things are not working out, then ACTH, corticosteroids, bromocriptine, and dantrolene becomes the next level of treatment for management of patients with catatonia. In addition to these classical movement disorders emergencies, there are so many other movement disorders emergencies of late coming into the primary picture. I'm not going to talk about them in detail here because for the limitation of the time, but however to give a bird's eye view, because these are all associated based upon the underlying etiology we have named these disorders. such as autoimmune disorders. Nowadays, autoimmune disorders are much more common, such as NMDR, encephalitis, or various types of like perm-induced encephalitis. Paraneoplastic syndromes should be kept in mind. Facial-brachial dystonic syndromes are one of the other causes which has probability of misinterpreted as being a seizure and being kept on treated as a seizure unless until you pick up these dystonic seizures, and treatment of this underlying autoimmune disorders helps you out. Opsoclonus myoclonus is commonly seen as a infectious or post-infectious or para-infectious syndrome among the children commonly seen, and it can present in various other causes also, even like drug-induced. As in this case, you can see that topiramate-induced opsoclonus myoclonus. So you need to keep these possibilities in mind. Look for underlying causes. Look for a proper history. That gives lot of understanding. Other things include ADCY5, which are presented as seizures many times or misinterpreted as seizures. Then oculogyric crisis, rare but can occur in many patients with advanced movement disorders, or some people with Parkinson's disease are highly sensitive to levodopa who can develop oculogyric crisis. And people who are having malignant or significant severe tic disorders, which can be motor tics or phonetic tics, where sometimes it becomes like an emergency or a semi-emergency type of a situation where treatment and approach needs to be managed. In addition to like any of the medical disorders where genuine causes are there, there can be mimickers, which can be kept in mind. So these can occur due to various situations, and we need to keep them in mind, especially when it comes to acute onset dystonias and which could be pseudodystonias due to atlantoaxial dislocations, tetanus, spinal cord tumor, acute inflammatory process of head and neck, especially in children who commonly have throat or ear infections presenting as dystonic presentations. So need to keep in these possibilities when people have ended up with you as a first referral for a first time, and then you have to look into it if anything was missing out in this case. So finally, to conclude, what I would like to tell is that movement disorders emergencies are wide and varied. There are significant number of underlying causes are there, which have to be systematically approached. Proper history of pre-existing illness, treatment history gives you most of the time the cue for what was the issue for that, and appropriate intervention for those leads to significant improvement, and avoiding going into an advanced phase means things can be managed at prodromal or early stages before it ends up with a severe form of a symptom for it. Proper management does give a good satisfactory outcome, not only for the treating doctors, for patients and families, for everyone, which should be appropriately assessed and managed. With this, I'll end my talk on movement disorders emergencies. If any other specific questions are there, we'll take it up at the end of the session. Thank you. Thanks a lot.